Hello and welcome to Pain Options Education. This is the place for discussion on topical issues in musculoskeletal pain for a common sense take on current research and evidence and to help fine tune your clinical practice. I'm your co-host, Darren.
And I'm the other guy, Tim.
Very good. We're continuing our discussion around pain sensitivity today. And this will be the third in the series, if I'm counting right, and we're looking at the subject of interview through a pain sensitivity lens. And this is our definition of pain sensitivity that we're working to still, or at least for the moment. Pain sensitivity in the clinical context can be considered as a term used to encompass the phenomena that some people's experience and perception of pain is enhanced beyond that of others. Anything changing your mind on that yet, Tim?
No, probably important that we are very aware of this in the subjective interview component of an assessment of someone, though, because it's their experience and perception. So that's where we get to hear about their experience and perception of their problem.
Yeah. Before we dig into the subject of itself, just a note on screening tools. There's screening tools for neuropathic pain and for pain sensitivity. It could be argued they measure the same thing in a lot of ways. Like, I think if you have neuropathic pain, you'd probably score high on a pain sensitivity questionnaire and potentially vice versa. A bit around that concept we spoke around in relation to Jonish's paper, where one can lead to the other. In the end, there are these questionnaires. They could be useful. Personally, I don't use them so much for screening, potentially more around putting a number or documenting the amount of pain sensitivity or neuropathic pain, particularly then to communicate that to others that I've used this validated questionnaire and that questionnaire is telling me this person has a neuropathic pain.
Yeah. So just to be clear, it's around the questionnaire that the person fills out. So it's really based on report of symptoms. Most of these, there is the odd one that also correlates that with physical findings.
Yeah.
But it just helps you identify, obviously for a neuropathic pain diagnosis, it can be an important part, but as you say, there's that crossover with similar symptoms for people with pain sensitivity, and it's a tool to help alert you that that's likely present. And as you say, it's important to give a measure at times depending when you're communicating the message. But I also don't use them with every patient, in that my subjective interview will lead me to that, which obviously we'll talk about a bit more.
Yeah, and I was thinking the same thing, like the Lance Leeds assessment of neuropathic symptoms and signs is one that does have subjective and objective components, and usually at the end I don't need to give that to the person because I can fill it out based on my assessment, because they're essentially yes/no questions and a couple of measures, physical measures. So screening tools are useful. We use the Orabro as our go-to initial screening tool. Doesn't really have a pain sensitivity element to it, but there could be use in these as well. Okay, when it comes to the subjective interview, just throwing these broad concepts around of patient-centered interviewing and motivational interviewing that try to put some structure behind what is essentially listening to the person and getting their story.
Yeah. There's two parts for my mind in this, and certainly with education I've done at the university setting as clinicians, and we're physiotherapists. Our role is to also find out information about a potential condition and rule out red flag disorders and rule out specific pathology. So part of our questioning needs to be quite closed and asking some yes/no answers around symptoms and behaviour of a person's symptoms. And that was traditionally how we were taught to gather information with patients, but really that's a small component of your interview with the patient. So understanding these different types of communication is really helpful for you to go, right, that's that part of it ticked off, but me dealing with that only helps a small proportion of people to understand their story and their bigger picture. There's a range of soft skills, some people call them, that do make you a lot more effective in understanding someone's story and getting, I guess, a clearer picture of what your role is, if any, to help that person out.
Mm. I mean, our setting is such, and our model of care really is that we have time to let people tell their story. And some people may be in a setting or a circumstance where there isn't a lot of time.
Yeah.
But in the end, this should be a priority.
Yeah, and time isn't the only factor. To get someone's full story in a complicated case takes time, but quite simply you can use these methods of communication even in shorter time frames to at least get the person's perspective so they're heard. There's plenty of research out there saying that a lot of people don't get to even share their perspective in a clinical encounter, regardless how short or long it is. So time is one issue, but you might not get it all done in the first session, so you can always cover off on more things later on if time is limited in your clinical encounter.
Yeah. And I think regardless of time, at the end, that nugget of kind of briefly repeating back what you've taken as the main picture of the story to so the patient can acknowledge that, oh yes, I have been heard. You can still do that regardless of time, can't you?
Yeah, so patient-centred interviewing around hearing their perspective, and then obviously motivational interviewing is a way of engaging that person to almost come up with the answers in one aspect so that they're clearly, I guess, engaging in that process and feeling like they're coming up with the solutions or being guided to the solutions rather than being told what to do, which we know there's plenty of work out there that shows that's a way more effective way of getting people to buy into a plan of any sort. Yeah.
Okay, good. So we have really just a table here of different things we'll go through. Some of them, most of them are general that you'd ask any patient. Maybe one or two, reflect specifically to pain sensitivity. But overall, I think we'll talk about these in relation to the person that is pain sensitive, understanding that it's a broader kind of interview.
Yeah.
So pain areas is the first one we have here. I guess in terms of how we're going about structuring this for wider consumption is having this concept of like, okay, if you answer a question related to your pain area one way, that might show that you're less likely to be sensitized.
Yeah.
Versus if you answer it another way where you're more likely to be sensitized. So if we kind of think about that construct, it might help as we go through this.
Yeah, and it's obviously not that dichotomous, it's a spectrum.
Yes, exactly.
Along that, but as a sense, if you're one end or the other, that increases your likelihood that you're more or less sensitive.
Yeah.
Yeah.
So if you're less sensitive, you're probably likely to have more localized pain, or if you have something like a radiculopathy, the location of that pain will be reasonably specific to the pathology involved.
Yeah, so discrete symptoms is more often than not associated with less pain sensitivity.
Yeah. Doesn't mean they're not feeling pain. As we said, pain sensitivity isn't related to the level of pain, but and then so on the flip side of that, when we start to hear stories of people that have more widespread pain symptoms, referral in non-dermatological patterns, dermatonal patterns, non-dermatonal patterns.
Oh, really?
Yes. Then you start to think, well, hang on, something else is going on here.
Yes, and I find this helpful if it's discrete and localised. Typically, this is a good patient to see, this will be quite straightforward, and I'll look good and be able to give them all the answers. Whereas the more widespread it is, they used to call them heart sink patients because it was going to be very complicated and take lots of your time.
Yeah.
Whereas I now view those as the interesting patients.
Yes, yeah.
And the more widespread the symptoms are, the less concerned I am around pathology as a guide.
Yeah, good point.
That said, there are certain conditions that you would need to screen for with your questioning that may be related to widespread pain that could be important. But broadly, if the pain's more localised, versus much more widespread, your thinking is already starting to shift of, okay, I need to gather more information around this, but I'm stepping back and hearing that as an important part of the story.
Yeah. So this is the person that will shade their back on the body chart, but then their whole leg, not just part of the leg, but the whole leg.
Yeah.
Yeah. What about when they colour in the whole body, Tim? Are you feeling so happy then?
Yeah, I'm okay with that.
Okay, good.
Because I'm suspecting there's going to be an interesting story.
Good. Yeah. I don't need to change slides. I think the next one's pain consistency. So I think this is around, people less sensitive or less likely for pain sensitivity to be a significant issue might have more intermittent symptoms.
Yep.
Those where pain sensitivity is a larger problem, it's more constant, and maybe we can bring intensity into this as well. They'll have constant high-level pain, and we've come up with a mandatory 8 out of 10 or more, but I think it's around the variability too, isn't it? So someone with less likely to be sensitive, they might have times where they're 0 or 1 or 2, times when they're 6 or 7 or more, whereas there'll be less variability for the pain sensitive person where their best is 7, average is 8, and worst is 10.
Or 12.
Yes.
Yeah, that's true. And again, this is to give you that on average what we see.
Yes.
But we can provide you with a number of exceptions to everything we're talking about here.
Yeah.
But if you're hearing that story of widespread pain and then it's constantly bad or really bad, then that's much more leaning towards, okay, my pain is just localised here. It's 0 most of the time, but it gets sore when I do certain things, then pain sensitivity is less likely to be relevant.
Right. Spontaneous pain. So this is a phenomena related to neuropathic pain in many ways. It's a sharp, piercing pain at rest. You have to be careful when you ask about this because somebody who gets a sharp pain moving from sitting to standing might think that's spontaneous pain, but we're really talking about spontaneous pain as a concept when you are at rest. Yeah. And then you get these pulsating sharp pains for no reason.
Yeah, they often say attacks of pain in that instance. And it's not the opposite of someone resting in a chair and then their back suddenly getting sorer and sorer. Yeah. That's also not spontaneous pain. It's random pain for no obvious cause or no clear provocation.
Yeah. If that's happening once a week, you probably wouldn't care. If it's hourly or more, then clearly it's more of an issue. Neurological symptoms. So particularly for the pain-sensitive person, I think this is around, those neurological symptoms are not in defined areas related to a nerve root or a specific nerve, that they're more non-dermatonal.
So you're talking numbness, pins and needles, dysesthesia?
Yes.
Yeah?
Yes. I would also say, I like to think of the patient where, you're talking to them and they go, oh yeah, I've got a sore back, I've got pain down my leg, oh my hands go numb. Well, in the past I would have said, well, that's nothing to do with your back. Yeah. Because anatomically it isn't.
Or you might have thought, there's some serious pathology going on somewhere else in your body.
That you need to screen out, exactly.
Yeah, which you could screen, and assuming you've done that.
Yes.
Then that numbness in their hands, what would that mean to you now?
Well, now I think there is a clear potential for the person that's sensitised to feel pain in body regions that are remote to their primary source of symptoms or symptom area.
Yeah, or other symptoms, not even pain, like numbness.
Yes, yeah. Okay, so, but again, really the pattern is different. It's not that classical kind of...
So you're clear neurological with radiculopathy or other neurological disorders.
Yeah.
You would screen for those, but your thinking is already shifting away from that given the other parts of the presentation that the person's described to you.
Yeah, exactly.
Yep.
Sensitivity itself, so you may... as you said, you're starting to get this kind of picture. You might specifically want to ask questions about sensitivity. Sensitivity to light touch is the one I tend to go to. So are your clothes, annoying you, your bra strap potentially, if someone lightly touches you, those kind of triggers.
Yeah, the bedclothes.
Yes.
And coming into winter in Perth now, the cold is...
Yeah, so then moving into temperature.
Yeah.
My favourite story remains the guy that would have the shower on hot wash the top half of his body and then turn it down to cold to do the lower half of his body. But, yeah, stuck in my mind that one for obvious reasons.
Yeah.
Now, look, there are other things around sensitivity to light, noise, those kind of things that some authors have related to sensitivity, and certainly they come to mind around migraines and things like that, which is, I think, theories suggest a sensitivity disorder in many ways.
Yeah, the nervous system.
Yeah.
So the thing to highlight here is, again, if you're listening to the story, people might bring this up.
Yeah.
But they often won't, because they will think it's not normal.
Yeah, exactly.
And they might not bring it up.
Yeah.
So that's where it's really helpful to have a couple of simple questions in your kit bag, if you like, to what you might ask. So what was yours, did you say?
I would specifically ask, do you feel like you are sensitive to light touch, somebody lightly touching you, clothes on their bed sheets, as you said, and then I might move to temperature, though you have to be careful around that one because people associate that with changes in the weather, not hot or cold. So
yeah. Good.
Okay. So pain behaviours, aggravating and easing activities.
Yeah, that's behaviours. People sometimes get a little bit confused around that someone's behaving like they've got lots of pain, which can be part of that, but it's also their symptom behaviour and how they respond to that, isn't it?
Yeah. So on the less pain sensitive person, I guess there can be clear aggravating and easing activities, positions and postures. They can find a place where they feel better. If they do specific things, then they can feel worse. The person that's more highly pain sensitized, potentially, they don't have that luxury. They're in pain all the time. Everything they do seems to aggravate that. They'll often change from position or posture rapidly, but then they're in the new posture and quickly that becomes uncomfortable. So they're spending their time changing positions all the time.
So I often find the things they say are that, well, there's no clear easing position other than to change position regularly.
Yeah.
So it's the moving around and changing, and that's just to modify, I guess, something in the system rather than a posture being better.
Yes.
And the other one around that is, I think of a knee as a good example, where someone says that they might be sore going up and down stairs, so you go, patellofemoral pain.
Yeah.
But then you might go, well, how many stairs and how long are you sore for?
Yeah.
And they might say, well, if I go up a flight of stairs, I'm sore for 2 days.
Yes.
Then that's not a typical response. So again, that fitting with the rest of their story makes you think a little bit differently about what might be going on. They may still have patellofemoral pain, but there might be this pain sensitivity along with that.
Agreed. Pain behaviours, anything else on that one?
Well, the other concept around pain behaviours is how people respond to pain as well. So that might be the grimacing, the breath holding, needing a walking stick, being very demonstrative. Carrying, one of my patients came in with 2 handbags, one for their usual things and another handbag for all their medication. They carried that in emergency. So that gives you, again, just more of a picture around that side of their pain.
It does. Psychosocial factors. So this is not a discussion around psychosocial factors, but you can't speak about this without touching on them. I guess the key, if you have to break it down to one thing that's relevant, is, do psychosocial factors influence their symptoms? Do they recognise that? Because that'll give you a clear link. It's not always clear, but
so at the moment, if we just keep this to the aggravating and easing factors, might be a simple way of thinking about this.
Yeah.
So when you might say to someone, does anything else increase or affect your pain?
Yeah.
And they might come up with this, and that happens a number of times where they say, well, definitely when I'm more stressed, my pain gets worse.
Yeah.
So that suggests, and we talked about this in an earlier episode, about this broader concept of sensitisation. So if they're system sensitised, so their nervous system through stress is sensitised, it makes sense with increased pain sensitivity, their symptoms might get worse.
Yes, yeah.
So that's the one example I could think of around that.
And I do think that treating psychosocial factors as an aggravating and easing activity is a very nice way to broach that with subjects where you've told me sitting for this period of time bothers you. Some people report that they're also aggravated by their mood.
Yep.
Do you find that? It's just a very easy way in, rather than do you have depression? Do you have anxiety? It's a bit more confrontational and.
Yeah, this gives you a context around it, and the person can clearly see why you're asking it.
Yeah. Comorbidities. So particularly this is around pain comorbidities or other disorders that might have a basis in pain sensitivity or sensitization as well. So migraines, unexplained stomach pains, irritable bowel syndrome, menstrual pain, pelvic pain, if you want to give that as another label, fibromyalgia as a whole body disorder, and restless leg syndrome are just some of the things that might be important.
And I will use this question when I'm trying to get someone's story and it's not making sense, that it's really mechanical, typical presentation from what they're telling me. So then I'll say, just out of interest, do you have any other pain conditions, or do you have these types of problems at all? And I had one more recently where someone had said, yes, they get migraines, but also they've had long-term sensitivity. They had a burn as a child, and now they've constantly had increased sensitivity on their back, for example. So again, that just feeds into that. This could fit with that overall picture of increased pain sensitivity.
Yeah. Likewise, I think of the person that's had ample treatment on their neck for headaches, but actually then when you speak to them, they have all this list of other things, and you're looking at a completely different, way of managing that. The way you manage simple cervicogenic headache is very different to somebody with widespread pain sensitivity disorder. And often, there is a lens. Oh, yeah, there's your pain. Let's just focus with that. You need to step back sometimes and take a whole person perspective.
Agreed.
And I think that can be very insightful for the person then, when all of a sudden you're linking all these things that they've had that no one else has necessarily drawn a line between.
Mm-hmm.
And then it comes back to prognosis and how important that is. I was going to click the button, but we're still here. Medications. Take any, Tim?
Me? Not today, Darren, no. If I was your patient and you were asking me about that, I guess that could give me some insights, couldn't it?
Yeah, I'm terrible. I always forget about medication, but I'm better than I am. I think the key thing is here, yes, as a physiotherapist or any medical practitioner, you should be asking about what medications there are, but particularly related to this topic is, are they on or have they tried medications that are meant to have some central acting effect on pain sensitivity?
Yeah, so on the central nervous system.
Yes.
So that could be your typical anti-neuropathic type medications, such as your gabapentin or pregabalin.
Yep.
Or it can be other medications, often for mood, such as your tricyclic antidepressants, for example. But we've got a new part of our online questionnaires now, Darren, that people fill out their medications for us, so you don't even have to bother asking. We can just check the list. But if they're taking those and they've clearly helped their symptoms, then that's what we're getting at there, isn't it? Yeah,
and it might influence the results of the physical assessment then, where there's this subjective story, but then objectively it's looking a little different, but that could be the influence of those medications.
Yep.
The other one is the opioids and the long-term use of those in terms of then winding the system up and having the opposite effect of what you want as well.
Yeah.
So important, and often also the person that has a presentation of pain sensitivity, but they've been given anti-inflammatories or simple Panadol, simple analgesics, which are less likely to have an effect on the disorders where this nervous system's wound up.
Yep.
So, yes, important.
Well, we could use an example of that around radiculopathy, where there can be different causes of radicular pain. So it could be inflammatory, so people with radicular pain that's associated with inflammation, the anti-inflammatories should help them.
Yes.
Whereas if it's mechanical nociceptive pain, then your painkiller should help them, versus if it's true neuropathic pain, then your anti-neuropathics might help. That's a one way of thinking around that, different effect from different medications.
Yeah, good. Fatigue and cognitive effects. I mean, fatigue's possibly a comorbidity and maybe an issue in these people. The cognitive effects are interesting. People will often report they're not able to concentrate as much. They're forgetful. Their brain just doesn't seem to be working normally for them. Now, you could put that down to side effects of medication, but also we know very early in the pain process there can be changes in the brain, and you have to wonder, at least, how much those changes in the brain could affect someone's cognition.
So there's certainly emerging research around this that we've come across fairly recently, but definitely to ask simple questions around fatigue, particularly around concentration, for example, or capacity to do their task in the absence of medication. It's very common in persistent pain broadly, not just with pain sensitisation, but it's just another component that adds to that story.
And okay, good. So body perception's the last one. Some people kind of align this with pain sensitivity. I personally think it's a different concept and construct. There are changes in the periphery related to changes in the homunculus. So maybe there's crossover pathways. I don't know the pathways well enough to, say if that's true or not. But it is different. It's not about pain. It's about perception. Though pain can be, elicited with it. The classic one to me is that fellow that I saw with complex regional pain syndrome, who you've seen a couple of times. He's moved over east, and he came in, and I was asking him some questions around this. I might have moved into the assessment, and then he's gone to me, you know what, I was sitting out there looking at your body chart and I just could not work out where to put it because it just seemed alien to my body. But he was too afraid to kind of mention that because it just seemed so ridiculous to him. Overall, body perception, well, we know can happen in localised musculoskeletal conditions as well, but it possibly is more of an issue in the pain-sensitive person.
Well, two parts. There'll be other things they might describe around not feeling connected to their body or not having good awareness with their limb, or they might have impaired balance, for example, around that, which may relate to this altered body perception, which isn't specific to pain sensitivity, but it may be highly relevant when we come to assessing and then managing, because if someone's very pain sensitive, a number of the things that we try and do to normalise their system can be aggravating, whereas body perceptual stuff might be an angle in around that. So it could be part of the picture.
Yeah. And maybe just mention the feedback questionnaire that Ben Wan's designed. If you're not sure about how to question around that, that is a screening questionnaire that works around that.
Yeah.
Okay, good. So any other things in the subjective assessment that you can think about?
Well, we've talked about a lot there, and it's quite broad, and it's intentionally broad because it's variable between people. And if you look at all those things that are listed there, we would consider all of those, but they won't all be relevant every time. So it's, again, the individual story that leads you to consider, okay, this isn't my stock standard mechanical nociceptive pain presentation. There's other things going on here. Just getting to that point alone is helpful as a starting point if you're not familiar with, I guess, working in this way or dealing with these types of patients.
Yeah.
Well, you've probably dealt with them, but you may not have been aware.
Yes. Yes, certainly that was me in the past. Great. I think we are moving on to paper of the day, and today we're doing it in Norwegian. We have some friends in Norway.
Yeah, you were there in January, so you would have been having a few Norwegian conversations, I think.
I can speak very good Norwegian after 3 very expensive Norwegian beers. So we'll do that at lunchtime and come back and I'll give you that one.
Good.
What is the paper of today? I've forgotten. Oh, it's this paper. Just pulled this out as a paper on motivational interviewing. I like to share this with the specialists in the residents in the specialist training program. what do you call them? Registrars? Yeah.
So those undertaking the specialist
Yes.
training? Yep.
Those are the ones. Now, I pulled out a quote here, Tim. So rolling with resistance is one of the concepts in this motivational interviewing structure. And they say confronting clients can evoke resistance and shut them down. Therefore, motivational interviewing counsellors roll with resistance rather than attempt to argue with the client. Maybe that's good sometimes, but I know at times you do confront people and do that very well. So just kind of wanted to get your reflections on that comment and maybe when that's not appropriate.
Well, I think it is appropriate most of the time.
Yes.
Is the short answer.
I only hear yelling at a patient once every 6 months.
You're just trying to get me in trouble here.
No.
So, and with pain sensitivity, that's very important. So if someone comes in with a sore knee and they've had an operation and it's not better and they know their knee's stuffed or they think their knee's stuffed, and for you to say, don't worry, it's just pain sensitivity, and they have an alternate belief for that, trying to argue with them there, you'll never see that person again and you won't be helpful.
Yeah.
There are times, though, when you've demonstrated with examination and you've got a person on board about a shift in thinking about what's wrong, where sometimes you do need to be quite direct and say, well, you're 3 operations in at this stage and it's not successful, why would you go for the 4th?
Yeah.
So sometimes, and that's absolutely a skill, and I'm not saying I've got that mastered because
It is a skill.
Because I still get it wrong, but at times the confrontation is relevant, but broadly the concept is if someone's not agreeing with you, they're obviously got either different beliefs or it hasn't been clarified, and you need to roll with that resistance and look to slowly shift them over time. So that's one of the skills around particularly pain sensitivity where it's relevant, because it's a complex group, and if what they've been told before or their belief system is different to what you're thinking is going on, motivational interviewing is a very important tool for that.
And absolutely, we don't have beliefs on here, and maybe that's an oversight. But as
it was under psychosocial.
Yeah, so we didn't talk about it in specific terms, but clearly very important in this area.
Yeah.
Most likely a person is going to have a very kind of stimulus response opinion of pain,
yes,
which we've already said is just not contemporary, or they might not know what's going on, but you need to understand their beliefs around their presentation if you're going to address it.
So there's probably 2 questions there. What do you understand is wrong?
Yeah.
So that's very helpful. And also around what do you think you need to get better, or what are your expectations out of coming to see us? If you have that information early, that helps you roll with certain resistance.
Yeah.
But if someone doesn't have a strong belief about what's wrong, or they've heard from someone but it's not a strongly held belief for them, then that you can confront quickly because it's often amenable to change. But if it's a strongly held belief, the rolling with resistance is absolutely important.
So what about the person that's highly sensitive? They have a goal or a belief that they can be 100% better. They've been the way they are for 18 months. Is that a realistic goal?
Well, it may not be, but it's not necessarily your job to change that. My step would be to set some shorter term, smaller goals, achievable ones, and who am I to tell them where they're going to end it ultimately? But let's break that down into smaller steps. I think it's a good way to get agreement early on of this is where we can head for now, then we can revise those goals as we go along.
Very good. Great. So we have any other questions, Tim?
I think you've asked a few. Maybe others might have a question.
They may, and they could email us at education@painoptions.com.au. And Tim's been checking that regularly, I know.
I have, hanging by the phone, so to speak.
It takes a lot of time, doesn't it?
It does.
Great. We will look forward to speaking to you next time.
Thanks.